Anisotropy, gosh, oh my gosh, I'm actually tired of saying the word, but it's important, especially to teach for people in the beginning stage. I think nothing is more important than understanding that concept at that stage. Because it's after the first 50 to 100 scans, like intentional scans, not just dabbling, that you start to understand it. And then in some cases, like in our cases and many others who are like at the advanced class master's level, they actually use it to their advantage. Okay,
Right.
so it could be a double-edged sword.
An advanced MSK Ultrasound Center podcast. From probe to practice. Hosted by Ryan Martin and Colin Rigney. Produced by Jason Kitza at NGG. Needgraders.com.
All right, hey, welcome to Probe to Practice. This is episode 3. I'm Colin Rigney, and I'm here with Ryan Martin. How's it going, man?
Hey, everybody. How's it going? Yep.
Awesome. Now, we're coming with today's episode. Well, first of all, how you doing, man?
I'm good. As you can see, I'm in one of the clinics here. I was seeing some patients, not one of the teaching days, but nope, just seeing some patients today. I'm doing good. How about you?
Doing great, doing great. My wife's mother is having surgery today, so kind of on standby with a few things. Everything will be okay, but it's kind of a routine surgery. But at her age, with anesthesia, there's always, the post recovery process. We're kind of anticipating that the next couple of days, but it's all good. I got the kids today. I braided my daughter's hair, and it wasn't unsuccessful. So I think I'm winning so far.
I've been in that boat before, and I'll tell you right now, it turns out I do not know how to braid. So it turns out I'm better at painting her nails than I am braiding hair. So we all have our specialties.
We all have our specialties. I might even post a picture of it later. She was happy with it. So
Oh, that's awesome, man.
yeah. So what are we talking about today? We got a couple good ones. Well, which one do you want to start with, man?
So we got a couple things that we want to talk about. Obviously, we like talking about, I like talking about physics and how to optimize images. Today we have a couple topics like anisotropy. It's kind of like the artifact that fools people. It's like the only imaging modality that you can create your own pathology with the flick of a wrist, right? And so I
Mhm.
want to kind of cover anisotropy because it's so pronounced in MSK ultrasound and it can make or break a good scan. So that's one thing that I kind of wanted to delve into. And then in a little bit, I want to talk a little bit about some terminologies of hypoechoic, hyperechoic, heterogeneous, homogeneous, anechoic. Some certain terminologies that people may or may not be getting right or wrong. And so maybe we can sum up like, hey, this is the correct way to use it, and this is why.
Mhm.
So
Mhm.
I really wanted to start with anisotropy, which is considered an artifact. So when we're talking about physics and optimization, and these are the kind of
I
things
thought it
that are
was a
going to,
cuss word.
well,
No?
it is a cuss word in sonography,
Okay.
but um, but it's one of those things where you will see these types of questions on the RMSK exam, and it's just something that you need to know because you can make something look torn or not torn, and submit that and be right or wrong. So I'm going to throw it at you a little bit. If we want to talk about anisotropy first, I think that's probably a good starting point.
I mean, anisotropy, gosh, oh my gosh, how I'm actually tired of saying the word, but it's important, especially to teach for people in the beginning stage. I think nothing is more important than understanding that concept at that stage. Because it's after the first 50 to 100 scans, like intentional scans, not just dabbling, that you start to understand it. And then in some cases, like in our cases and many others who are like at the advanced class master's level, they actually use it to their advantage. Okay,
Right.
so it could be a double-edged sword. I'll let you talk the physics part, but I'll talk like the philosophical side of
Okay.
using it because in the beginning stage is really going to fool you.
Right.
I
Well, let
used to
me
think
start.
everything,
Yeah.
everything was tendinosis, something was gone. Um, you know, I never knew I never knew an incidental finding versus a false positive, or in some cases a false negative.
Right.
Um, but like that's where my brain goes with it. And then, um, you know, now using that with your motor skills of, how you're actually moving the probe on the skin and what makes it occur and what doesn't. So I'll kick it to you on that. What's some
Sure.
tips for people to first understand it and mitigate it?
Yeah, I think it should probably be defined a little bit better for most people. So anisotropy, it's an angle dependent artifact, meaning depending on how you're holding your probe is going to change what you see on the screen. So what happens is uh, um, the beam is not completely perpendicular. So if you're looking at a plane of motion and you have a beam coming down, that's going to be perpendicular, right? That 90-degree angle. If you're at a skewed angle, that's no longer 90. And what tends to happen is sound scatters away from the probe and you get less signal returning to the device. So if you have less signal returning to the device, you're not going to get as crisp of an image, and you're also going to have less return of echogenicity. And we'll talk more about those terms here in a little bit, but it won't be as bright. The tissue will artificially look darker or hypoechoic, and now normal tissue just suddenly appears pathologic. So that's the biggest way to explain it, is it's an angle dependent artifact. And when I tell my residents, or we tell our students, or the way we teach, is this is user error, right? And when I say user error, it can also be used to your advantage, because you were saying that before, and I'll let you kind of talk about some of that stuff. So I think we use this in clinic all the time to help us locate things. For example, if
Mhm.
I'm down at the peroneus or the fibularis group and I can't discern between the longus and the brevis, if I just toggle my probe, and tip that tail back and forth, I can see them winking back and forth and say, okay, there's longus, there's brevis, there's longus, there's brevis. And so we can use it to our advantage. Or if we have like just an amalgam, like this tissue that looks cruddy and degenerative, and maybe there's microvascular disease or whatever, and you're looking for the tendon, if you toggle that and that tendon flashes in and out around some scar tissue, that's helpful as well. But the downside is if you don't have that angle right, and the human body rarely gives you a nice 90-degree angle for every image, if you don't have that angle right, you might miscall things. So
Yeah.
some of the biggest ones that we find anisotropy is going to be supraspinatus, patellar tendon, Achilles, common extensor, the distal bicep. Like if you can't get those right, they're going to show you some shadowing or some false positives, and sometimes even false negatives.
Yeah. Quad tendon too.
Oh, yeah, for sure.
Can I ask you a couple of questions?
Yeah.
So for that angle, you talked about being perpendicular 90 degrees. Is there a margin for error? Like, can you be slightly off and still be like within um, acceptable bounds?
Yeah, and this is mainly because of the transducers themselves do not just have sound beams that go straight out. So they have multi-array type of lines. I can go into further detail if I had a whiteboard here, but the reason that they have sound waves that kind of travel in multiple angles is so you can pick up on some of that anisotropy and have a little bit more room for error. But over 15, 20, 30 degrees, you're going to get more and more anisotropy. Even starting at as low as 5 degrees, you might start getting changes. So that's why
Yeah.
we have to really practice heel to toe and toggling to make sure that we're not getting those anisotropic
hmm
changes. So yes, there is a margin of error, and it starts around 5 degrees, but you're really going to start noticing it past 10, 15, and 20.
Yeah, that's important because I think we don't want to create too much of a perfection. I mean, we all want to be as good as possible and great. But especially when you're just beginning, understand that there is a margin for error with the slight angle variability. Now, you did a whole course on this in our introduction to musculoskeletal ultrasound. And I think we should put a link for that in today's description. But another question on really now I want to blend this a little bit. So go a little bit beyond anisotropy. Um, but anechoic, hyperechoic, hypoechoic. So tell the audience a little bit about how let's go with like absence of sound versus hypoechoic. How do you know if something is a truly absent of sound or is sound waves versus is just being anisotropic? Like, can you give us like a couple examples that maybe it's in a lot of those, I don't want to put the word in your mouth, but tissue examples, pathology examples, like if you can
Yeah.
just walk us through a couple of those.
Yeah. So I think the foundations need to be explained first, right? And so echotexture is how tissue reflects sound. That is just a general term, right? And you're interpreting everything from brightness, the pattern, uniformity, and architecture. And then from those terms, we can decide, is it dark? Is it light? Is it somewhere in between? And that's where we get the terms hyper, hypo, anechoic. And we have to be specific to its relative to the surrounding tissue, meaning something could be hyperechoic in one environment, but hypoechoic in another. Same tissue, different echogenicity. So let's talk a little bit about what hyper is, what hypo is, and what anechoic is. And then let's give some tissue examples, right? So hyperechoic is brighter on the screen, right? So more sound waves return for that specific tissue. So it'll turn lighter, whiter, brighter on the screen, whereas hypoechoic is darker in relationship to other tissue. Now, when you're talking anechoic, that is void of return, right? And so when do we see that? Well, if we see it in air, we see it in fluid, we have it with things that do not have resistance, AKA impedance. So if the impedance is higher and you can't go through a structure, it's going to be brighter. The less dense that tissue gets, the darker it becomes. So you think about fluid versus a bone, right? Well, which one's going to be more dense, right? The bone in relationship, right? And so that's going to look hyper or brighter in relationship to other tissue. Other examples are going to be lung fields. So you have more air, you have fluid spaces, you have anything from like ganglion cysts that have a synovial proliferation pocket. These are the things that are going to look hypoechoic and sometimes even anechoic. And it's tough to sometimes discern because, I mean, in reality, most machines have 256 shades of gray. And so it's like, all right, what shade am I looking at? Well, we're going to determine that in relationship to the other tissues. So for example, if I'm looking at the median nerve, between the superficialis and the profundus of the forearm here, it's going to look pretty hyperechoic because it's more dense compared to the muscular tissue. However, as it travels distal, what's going to happen? Well, now it's going to be surrounded by ligamentous, tendinous spaces, and those have density to them. So now, in relationship to the rest of the tissue, it turns hypoechoic in relationship to the, so it's all relative to where you're looking and what you're looking at it against the rest of that environment. And it gets complex. And this probably why I like teaching this is because the complexity can be broken down so simply. And I think you're right. A link for the physics and optimization course should be kind of listed in here somewhere. But yeah, that's hyper, hypo, anechoic, and a few tissue, relative tissues that we could talk about.
Okay. Now, let's talk about patient positioning in a couple maybe case examples.
Yeah.
Common errors in evaluating. You know, we named a few tissues, but let's start with some easy ones, like distal quad and patellar tendon. What are some common pitfalls in evaluating, you know, patellar tendinosis and patient position? What are some common mistakes that you've seen made and easy ways to correct them?
Yeah. Okay. So patient positioning is key. It's imperative. I don't know. Let's start with the Achilles. So if you have your patient seated and they're in a favored position and their foot has a little bit of plantar flexion, that's not key. That's not ideal, right? Because the Achilles is going to have some slack to it. What I recommend in those type of scenarios is you have them prone, hanging their foot over the table, and you can put a little stress into neutral or to dorsiflexion, which will put that Achilles into a little bit more stretch. Now, if that Achilles bows because it's relaxed, that might give you the contour that might change your anisotropy. So it might change your angle and it might change what it looks like. And so I recommend putting things on tension if you can, help those fibers get taut and help them get a little bit more aligned so they're more parallel with each other and perpendicular to the sound wave. So that's how I would do it in, say, something like an Achilles. Same thing with the quad tendon, is if you have too much extension, it'll go slack. If you get too much flexion, it's going to compress the joint capsule, so you may not get the fibers that you want as well. Yeah, those are kind of like the examples. The Achilles is the big one that I see people misinterpret because they don't understand how to put that biomechanically or anatomically, put that tissue on tension. And it's just a simple matter of, hey, are you comfortable laying on your stomach? Can you hang your foot off the edge? I'm going to put a little pressure on the ball of your foot, create a little bit of dorsiflexion, and that's going to help that probe sit a little better and perpendicular beams to that tissue.
Mm-hmm.
Is that helpful?
Yeah. So, I mean, a little bit of thought has to go into, as clinicians, how we position the patient, right?
Absolutely.
And the concept of putting something on a stretch, I always tell people this, like, you're going to see whatever you want to see generally, with a few exceptions. Okay, there's outliers. Better if you put the tissue on a stretch. You know what I mean? So what you just described there was kind of classic to that. So for anybody who's beginning and you're evaluating like an insertional tendon, any kind of insertional tendon, you're always going to see it better with that structure on a bit of a stretch.
Yeah.
So that's my piece of input after what you just described there. So so you went through the density of tissues, and it's the same density with when you're talking about any imaging modality. Really, X-rays and fluoroscopy and even CT, these laws still apply. So from most dense to least dense, we have bone to air, essentially, right?
Yeah, absolutely.
What type of, can you go through, and you kind of did this, but let's
I
put
think
a little
Colin froze. Hard to determine what type. You cut off a little bit. What now? What were you saying? What type of something?
Okay, yeah. What type of like pathology conditions, clinical thinking with when you're seeing, anechoic to hypoechoic to hyperechoic. If you see something that's, let's talk. You gave some joint examples, but let's talk about like a rotator cuff or a mid belly muscle tear. How do those tissue characteristics help you define and get into a work, maybe not define, but have a working diagnosis from your study?
Right. Well, I think, and when we go over sonoanatomy and how things should naturally appear on the screen, we know that muscle tends to have like this sinuated feathery architecture, and it has mixed echogenicity. So it does have, it has striations in there. It has fascial planes in there. So you're going to have a mix of hyper, right? But if you have a significant change in homogeny. So when we talk homogeneous versus heterogeneous, it doesn't mean that there's a texture to it. It means there's a change in texture. And the clinical or the pearl that I used to get from Dr. Joel Sellers, one of our great mentors and colleagues, is he would look at a wall that had a pattern on it. So like, you just look at a normal wall that has a little texture to it. And he says, all right, now you look at that wall and it has texture, but the texture is continuous throughout the entire wall. That's still homogeneous, right? Whereas if you go and scuff it, put holes in it, now that's heterogeneous, or it's a deviation of that normal architecture. Same thing with muscles. So you brought up muscle as, all right, how do we define that and how do we look at that as a pathology? So if that feathery architecture or that mixed echogenicity that is consistent through the muscle has now changed or been disrupted, typically it's going to be a tear. If it's a tear, it's going to be hypoechoic. Well, luckily, I just wrote an entire lecture on acute versus chronic. And one of the things with an acute injury is going to be the formation of a hematoma in this area. So a hematoma is going to have blood, which is going to be more fluid based, right? Which means it's going to be more hypoechoic within the mixture of that feathery architecture. Now, if it's a little bit more chronic from a tear, now you might be seeing things like myositis ossificans, whereas that tissue is now coagulated and starting to ossify. And now that tissue actually has a hyperechoic space within that feathery architecture. So again, your clinical brain has to be discerning, all right, this makes sense to their muscles denervated. How does that look, right? And Colin, I'll let you answer that. How does a denervated muscle tend to look?
Yeah. Well, the tissue archetype of a muscle is on ultrasound is, in terms of appearance, is generally hypoechoic. It's mixed, right? So that it's hypoechoic, it's high in water content. So it's going to be darker. And then it's going to have patches of fascia interposed, right? And that's where the term starry night pattern in healthy muscle tissue comes from. Now, let's reverse engineer that from when something's denervated, right? If a muscle is being denied conductivity in the form of how it gets input to contract, it's going to atrophy. And when a tissue atrophies, specifically muscle, it's going to lose its hydration. It's going to lose its hypoechoic appearance over time. And it starts slow and then it kind of goes rapidly and it turns very hyperechoic at that point. And when a muscle is in a period of disuse or a state of disuse, fatty deposition starts to set in. And not only does it become more hyperechoic in general, it's going to start becoming homogeneously heterogeneous. If that is
Homogeneously heterogeneous.
So
that's great.
Dr. Weinstein,
that's a Dr.
Weinstein. Yeah, that's a Dr. Weinstein term.
But let's say, for example, if you suspected the right leg to have, like some sort of denervation or atrophic type of changes, what could you do to cross-reference that?
Check the other side, right?
Yeah, right. And so if you checked it from left to right, say, I don't know, let's just say an infraspinatus, and you have a cuff pathology and you look at the right side and it looks like a cloud rolled through in San Francisco over the Golden Gate, right over that muscle belly. And then you look at the left contralateral side and it looks like that feathery architecture. Well, there you have it.
Yeah, you can always too, Ryan. You can also track its diameter over time as long as you're taking the measurement in the same place. And so for our PTs out there, that's one means to objectively track progress of what you're working on, right? In your ACL populations, if you do these post-operatively, right, you can measure pick a muscle, right? Usually rectus fem, or you could take a vastus medialis, whatever you decide to do. I guess that's up to you. But don't forget that we have these tools on the machine that can help us be more precise with its state of health or disease, right? And that's just one example.
I love that because, and again, now you're skating around or skating towards a topic that needs to be discussed down the road, which is RUSI, right? Rehabilitative ultrasound, which I think is a good biomarker for advancement, progression, and checking how things work and how they progress, and utilizing it to show patients how they're contracting or not contracting muscles, or how it's atrophic and how it's changing. I think that's a topic that we should explore later as well, is RUSI. But let's kind of wrap up here and just kind of ask, is there anything that you want to discuss about anisotropy as an artifact, anechoic, or anything else that you want to wrap up here?
No, I think people, if you're really looking to get started and you're interested, you need to buy Ryan's course, Introduction to MSK Ultrasound. I think that there is a lot of depth to it, and certainly what we talked about today, right, is very broad based, and hopefully it was provided some value in terms of where you're at, no matter stage of learning you're in. But with today, right, the final concept I'll just go over again. It'll be a little more philosophical, but at the end of the day, you have to understand these things in order to get to the next stage. And if you don't fully understand it, you're going to suboptimally start. If you're not getting the feedback, right, how do you know where you're at?
Yeah.
You shouldn't compare yourself to people who are, on the same stage as you or below, right? You're not going to get better that way. You have to continuously learn and apply these things in order to get to the next stage. So understanding the fundamentals, I go back to blocking and tackling for football, skating backwards in hockey. You have to know, and you have to know the terminologies and how they can be used for and against you, right? And so I'll just end with that as from a philosophical perspective.
Well, then I'll put my 2 cents in as well. Then, ultrasound isn't just imaging; it's real-time interrogation, right? And if you don't understand artifacts and echo texture, the machine will lie to you all day long. And I would say to you, don't be that sonographer, don't be that clinician, don't be that professional that misses out on things because they didn't understand simple artifacts. That's the last thing I'll say on that.
Right, exactly. Well, I think
people say I don't have time. You have time. Everybody has time. It's just how do you prioritize it?
Don't forget what got you here. Like, this is just a tool. It's not replacing like your clinical skills and background.
Hey, I know the grass is greener over there, but I just don't want to make the effort to climb over the fence.
And diagnostic musculoskeletal ultrasound really is the next generation. And if you are not embracing it, you are going to be left behind, period. And it's an extension of your physical exam.
An advanced MSK Ultrasound Center podcast. From probe to practice. Hosted by Ryan Martin and Colin Rigney. Produced by Jason Kitza at NGG, needgraders.com. If you have any questions about today's episode, or are curious to know more about AMSKU, visit amsku.com or check the links in the show notes.